me to stop in between to explain anything, I'll tell. Definitely. And after that, there are a set of videos which I want you to watch. Okay? Not the cartoon videos. It is about the PFCS, the Patello pain syndrome, where it's an evidence-based perspective it is. So what is actually going on with the treatment of the Patello pain syndrome? There is another speaker after me who is coming for chondromalacia patella. Okay? So hope you are all clear about my objective here for the next maybe now 20 minutes only. Okay? Bear with all of us. Shall we proceed? Okay? Again, the link for the presentation as I gave in the morning session. This link also you can have it from me personally also. After the presentation you can come and approach me and I'll give you. I'll be very happy to give you any of the links. Okay? I acknowledge specifically one of my students who was a model for all the speakers and other students who was for the photos and the videos. Remember when someone comes with anterior knee pain or patellofemoral pain, just remember the anatomy. Okay? Anteriorly, what all structures are there? Around the patella, what are there? What ligaments, what muscles, what tendons, what bursa, which bones, okay? Which fascia, and capsule, synovium, all the innervated structures will be producing pain. Not that it's only the patellar articular cartilage is causing pain. Never. All the structures will be what is called as the source of symptoms. So try to list all the structures in your mind, check all the structures by palpation and also by movement testing. Try to confirm your hypothesis and try to arrive at a diagnosis. Okay? What is this term patellofemoral pain syndrome? I want you to actually know. And then we are talking about evidence-based practice in the morning, but we are here evidence-based clinical practice guidelines. Okay? That's our term also I want you to remember. Even if you don't know what is the term, no problem. It's a guideline. Then patellar examination, what all you can do. There are some 5 clinical tests which have been highly validated and useful in diagnosing patellofemoral pain, classification of patellofemoral pain. And remember, when you give post-kinetic pain exercises, to give only 0 to 30 degrees. So it's a mini lunges. Okay, that's the only option for treatment, and you can give it with the toe in or the toe out or the neutral toe position, no problem. Or you can give bilateral squat also. It can be a wall lean squat where you keep your line of gravity posterior. So you lean on the wall and then you go into a squat, partial squat. You can do any of these options. Patellar taping is another intervention which has been having evidence. Joint mobilization as part of exercise therapy. Okay, in patellofemoral pain syndrome, it is patellar mobilization. So these are the messages. Okay, I want you all to remember this within quotes. So I am going to say what is this. You are going to see what are the assessments and what are the treatments, and you will copy when and where necessary. Okay, let's proceed. Parapatellar, both sides of the patella. Peripatellar, around the patella. Retropatellar is behind the patella. Okay, there are some terminology. Purely anatomical. That means it's the site of the symptom. Don't want me to stop. Very good. Remember definitely that the presentation is already uploaded. Okay, it is already there in the link which I have given. There was one case which was found for patellofemoral pain syndrome. It was specific to the activity which aggravate the symptoms in patellofemoral pain. When they have validated this case, that I thought would be more relevant in assessment. We move. Next slide. Yes. Fantastic. Yeah? Observation you want to explain? Very good. You observe from there. Okay. Remember, when you are observing anterior and posterior and lateral view, anteroposterior view is trying to see for genovalgum or tibia varum or valgum or the subtalar deviation, calcaneal deviation. and in the lateral view observe for the genuine curvature. It's fine? Not fine. So after you observe the patient in bipedal stance, observe in unilateral stance, unipedal stance. Because if unilateral symptoms are there, during weight bearing of that will reproduce the symptoms. So see for the change in alignment between bipedal stance and unipedal stance. Right there is symptomatic. Leg in stand with both legs, leg in stand on only on right leg. See for the deviation in either the alignment of the tibia, femur or the subtalar neutral. This movement, examine the knee flexion with keeping neutral and also with keeping flexion. Those kinetic chain movements, observe for squatting, you can also observe. Observe for the patellar position in sitting, also for the Q angle, the angulation which is there between the femur and the tibia, even anatomical valgus, that also disappears in sitting. So they all come in straight line. That is the ASIS, center of patella and the tibial tubercle, all this form a straight line in sitting. And then the next one is the patellar position. Patella should face anteriorly, it should not face superiorly. Okay, when you are seeing from the lateral view in sitting. So observe. Observe for again. What are you observe? The only difference between standing observation and supine and prone observation is, what is the difference between these two observations? No. What is the difference between sitting and lying down? What is the difference between standing and lying down? Non-weight bearing, exactly. Fantastic answer. Okay. It is non-weight bearing. Supine and prone is non-weight bearing observation. The standing one is weight bearing observation. Standing also you do static observation and then you do dynamic. Okay. So categorize the observation into all these categories. Observe for the knee flexion in the prone position and then try to add hip extension to differentiate the structure which is crossing the hip also. For example, rectus femoris. If you add hip extension and then range is further limited, you can suspect hip is also crossing. Alignment of hip activation, the values were mentioned by the authors, where increased activation is correlated to increased internal rotation of the hip, lateral and decrease, assessment of the leg length. Try to see for the longer leg. The presence of longer leg, the longer side is prone for patellar pain because of the flexion moment. And then knee flexion is performed in the supine and see for the range and the palpate is one hand for the dynamic crepitus. Okay, whether it is soft crepitus, whether it is from the synovial folds or the hard crepitus if it is from the osteophyte. Okay. Palpation see for with respect to the surface anatomy, medial, lateral, anterior, posterior, and also inferior, superior. Okay. When you push into medial glide, after that you palpate the medial facet from posterior direction. Okay, from down. Try to palpate the facet to confirm the articular cartilage changes. Okay. Similar laterally. There is one classification proposed by McDonald, I am not going to tell you now. Okay. Lateral glide and you can palpate the lateral facet. After inferior glide, you can palpate the inferior facet also, and after the superior glide, you can palpate the superior pole. Okay. Hamstring muscle length, 90-degree position, and then you extend the leg. What you try to observe here is for the tension of the medial and the lateral hamstring. Differentiate the medial hamstring by extending the knee with the external rotation of the leg. Okay, and the lateral hamstring, you will extend the knee with medial rotation of the leg. Okay. Okay. Gastrocnemius length, you do ankle dorsiflexion in knee extension and knee flexion. Try to differentiate the range of the dorsiflexion. Psoriasis side is the dorsiflexion with knee flexus. Physiotherapical band length, you saw the video of my teacher. Okay. I don't have to tell anything about it. Thomas test also you saw. The first of the special tests, which I told you, 5 special tests, is the vastus medial coordination test, where you ask the patient to lift the heel of the bed with your hand below the popliteal fossa, and if the patient presses your hand before lifting the leg, it indicates an incoordination of the vastus medialis. Okay? You should not press on your hand. You should lift the heel directly, immediate activation. Okay, VMO. If there is a delay, patellar femoral pain. Apprehension test, give a lateral glide to the patella, passively move the knee to 0 to 30 degrees, again back. The patient will complain of giving a sensation. Okay, apprehension. Class test. Put the patella medially, stabilize it, ask the patient to activate the quadriceps. Symptoms are reproduced, positive test. Valve test, simple. You compress the patellofemoral joint and then ask the patient to move 0 to 30 degrees. Symptoms are reproduced, positive test. It's the part 1, that is open kinematic. Closed kinematic, you ask the patient to squat with giving the compression. Okay? And then the last of the test, which is the most important provocative test, that is the eccentric step test. Usually patients complain of this position. Okay, when you are climbing downstairs, patients will complain of hyperkinesia. So try to reproduce the symptoms, asking the patient to step down on the symptomatic side. Q angle, I am not explaining how to measure Q angle. Okay? Normal values. Check out Q angle is termed as the physiological valgus. It's the contraction of the quadriceps, angle of pull of the quadriceps. Anatomical valgus is the long axis of femur and the long axis of the tibia. Try to understand both the terms. This is skeletal, that is muscular. Q angle is muscular. Okay? A angle, it finds the rotational abnormalities of the patella. Okay, try to see for the bisector of the superior pole of the A angle, the patella to the inferior pole and then project it down. And the next one is from tibial tubercle to inferior pole and project it up. Okay? The difference, A angle is very poorly reliable. And another index is there which is radiologically also measured. You can see clinically where the length of the patella versus length of the patellar tendon. If the patella is smaller than the patellar tendon, it indicates the patella alta. Okay, patella may be higher. So ligament of patella may be longer. Okay. Tibial torsion. Try to see the angle formed in the transverse plane between the intercondylar axis and the intermalleolar axis of the tibia. Okay, rotation. Investigations depends upon the presentation of the patient. We are not going to refer. We are excellent orthopedic surgeons. Classification, remember there are only 3 terms. Patellofemoral instability could be one of the patellofemoral pain syndrome, or patellofemoral pain with malalignment and patellofemoral pain without malalignment. 3 categories. Coming to treatment, ultrasound was proven to be effective as an adjunct in the Cochrane systematic review, but not when used alone. Exercise therapy. When you do static quadriceps, you think of, static quadriceps only. There is nothing in it, static quadriceps, every time static quadriceps. Okay? You can observe for the activation of the quadriceps and patellar movement and train on the contraction. May I know how many minutes, sir? 4 minutes? Okay, great. So see for the lunges, some of the treatments. Okay, exercise therapy evidence was there compared to the no exercise. And open and closed kinetic are equally beneficial in patellofemoral pain. And this is an interesting video which I was really okay. Mouse has come. Got the mouse. Okay. I think I am having the same problem what I had yesterday. The video is not playing, it's for a medial glide. Okay. These are the videos for patellar mobilization. Okay. You have this is superior and inferior glide, this is for lateral glide. This is for medial and lateral rotation, the position of the hand. This is for tilting, that is medial tilt, lateral tilt, inferior tilt, superior tilt. Compression of the patellofemoral joint you can give as a chronic stage. Okay, you can induce compression. Rhythmic compression will improve the circulation of the cartilage. Sustained compression will lead to the injury. Okay, so don't think compression again we are producing. Okay, distraction beautiful. Acute stage also you can do to relieve the compression of the patellofemoral symptoms. Taping, again evidence not from the Cochrane review but from other reviews which support taping. That's what it is. Okay, there are some evidence-based clinical practice guidelines which are proposed by the Australian Physiotherapy Association. Okay, they are always forerunners for physiotherapy, and they have found evidence of benefit for some of the modalities and evidence of conflicting evidence. Okay, for some other modalities, insufficient evidence, and last laser was found to have evidence of no benefit. Okay, so remember this. Okay, what we should not know is first thing. After that is what we can do. Okay, and references. The presentation was built upon the works of many. Okay? Was beautiful studies. Okay? I'm almost on the verge of finishing, so you take another minute extra. Okay? These are the references for the guidelines. Evidence-based clinical practice guidelines. You will get fantastic information from this. And any further information, you can always keep in touch with the organizing committee also, or of myself. Okay. This is the second one, is the Australian Physiotherapy Association. The guideline reference. Directly you have to type in the browser's address bar, and you have to click enter. The PDF file starts downloading, and you will get a full. It's around 185 to 200 pages more. It's the acute musculoskeletal pain, all the pain. Evidence-based clinical practice guidelines is very, very useful as a physiotherapist. Okay. Take home message again. Is the term familiar? No problem. That's what I'm saying. Clinical practice guidelines. Patello examination. The 5 clinical tests. What are the 5 clinical tests? Velasamy Ravendran what is test? Patello application test. Class test. Valence test. Yeah, 2 types, 2 parts of valence test. Then the fifth one? Excellent test. You are fantastic. My goodness. You are amazing. Okay. Thank you, sir. Thank you so much. Thank you. Please examine the applause for your welcome. Thank you so much. Really delighted.
Thank you very much for the excellent presentation. I must say that